Good morning. I am Craig Primack. I'm the president of the Obesity Medicine Association. Today, I'm going to talk to you about the medical science of obesity. I want to start by telling you a story about myself. I grew up north of Chicago, went to a small school in a small town, and I played tennis on our high school tennis team. My friend John and I became our #1 doubles team. Well, fast forward a few years, and I went to medical school. I moved to Arizona, got married, had kids, and started looking for an activity to do. So I started playing tennis again, first taking some private lessons, and then playing with a doubles group. I think I did it for about a year. I think I got pretty good. Well, at least pretty good for a guy who works, has a baby, and was doing this in his extra free time. I could hit with topspin. I had a nice yet one-handed backhand. And again, I thought I was pretty good. So I recall, after this year of lessons, I made plans to play one of my friends who at the time didn't play much tennis. First, we hit for just maybe 20 or 30 minutes, and I was happy with my skills. When we actually started to play a set or two, that's when things changed. If he hit the ball to me, I'm really good at returning it back. But then he started mixing it up. That's what you do when you're actually playing. You hit a long one, you hit a short one, you hit a little left, you hit a little right. So on the short one, I'm late getting to the ball. And I either hit it right in the net or hit it right back to him at the net, and he just put it away. He kept mixing it up long, short, and me, when it's short, I'm late on the ball. Remember, me, who was originally really cocky, did not win either set that we played. Sometime, not long after that, I was at the eye doctor for a routine exam, and he had me put on a pair of 3D glasses. And there were 4 circles, and I had to tell him which circle was closest to me. It's a test that measures depth perception. Well, I didn't do so well. The doctor told me that my depth perception was definitely not normal, and there was not a lot that they could do about it. Then things started to click. It started to make sense. Without cues from around the periphery, for example, like I could see in the daylight, I noticed that at night, when pulling up to an intersection with my car, I was stopping too soon before the red light. When the ball was hit short, I couldn't see it right away. That was it. It's not that I'm officially bad at tennis. It's not that I'm bad at hitting the ball. It's not that I'm not trying really hard or that I'm not mobile. It's that I just don't see the ball like other people see the ball. If you hit it short, I'm late on the ball. Not because I'm really bad. But unless you change your stroke significantly so that I can see that you've changed it, then I don't see the ball as short and I'm late running up to it. I don't see the ball like other people see the ball. I want to be a good tennis player. I practiced really, really hard. I had a lot of willpower. But at this point, once my weakness is figured out, it's easily taken advantage of. Fast forward, in 2004, I started practicing some weight loss as part of my primary care practice. In 2006, with my business partner, I started my own clinic and gave up primary care. Fast forward again to 2011, now practicing weight loss full-time for about 5 years. I was actually at an OMA meeting when I heard about an article that explained to me why people with weight problems have weight problems. You think to yourself, I know why people with weight problems have weight problems. Well, you believe people who are overweight just eat too much and maybe generally just don't exercise enough. This is what we call eat less and move more, ELMM. Do you think it's just eat less and move more? Do you think that out of every 3 out of 4 people who struggle with their weight have not been told to eat less and move more? Do you think it's that they can't? Or do you think it's that they won't? So let's go back to the article. The article was published in the New England Journal of Medicine, one of our most prestigious journals in the US. We call it the Sumithran article. The Sumithran article showed for the first time that people in this study, and there's about 50 of them, who were overweight were able to lose weight over about 10 weeks. And then they were followed for a year. Let me back up. You know that hunger and fullness are controlled by hormones, these chemicals in the blood that allow one part of our body to speak to another part of our body. The stomach, the intestines, the fat, the pancreas, and the gallbladder can tell the brain that I'm either hungry or full. The two most common and well-studied of these are leptin and ghrelin. We want leptin to be high. It's coming from the fat stores itself. We want ghrelin to be low, which comes from the stomach. Well, these hormones that control appetite were found to be changed in this study. Let me say this again. The hormones that controlled appetite when we lose weight were changed. These changes are what we call counter-regulatory in people who are overweight. They work to increase hunger and decrease fullness. The leptin tells us that we're full goes down, and the ghrelin that tells us that we're hungry goes up. And they stay that way. Therefore, over time, pushing us, encouraging us, because now we're less full and more hungry than we used to be, pushing us to gain the weight or regain the weight that we have lost. It's like there's this little guy sitting on your shoulder, and he's yelling right at your brain. And as you lose weight, he begins to whisper, eat, eat. And the more weight you lose, the louder he gets, eat, eat. And so when you see food, eat. When you should be full, you eat. And when you used to be able to stop and pass up dessert, or that next piece of pizza, or the full order of fries, you now eat it. You don't have hunger and fullness like other people. The key to treating obesity, this disease of being overweight, is to block those abnormal signals before they're getting to the brain. It's like putting earmuffs on. The guy is still shouting, but you just don't hear it. I think there's 5 ways to install these earmuffs. The strongest, the one that we are always dedicated to, is using medications to block those signals, or getting you off medicines that are causing increased hunger. It's some type of dietary change with less calories, of course, often with higher protein and less carbohydrate. It's gentle exercise. It's restorative sleep of at least 7 hours, and most likely at least 64 ounces of water. Yes, so I'm a physician who treats people for obesity and overweight. This specialty that we're all part of is called obesity medicine. This whole medical specialty dedicated for treating the over 100 million people that have overweight and obesity, and at least another, we'll call it medical diagnosis, like blood pressure, diabetes, or high cholesterol. As of last spring, 2020, there were over 4,100 physicians who are diplomats of the American Board of Obesity Medicine, as well as many other nurse practitioners and physician assistants, or PAs, who have dedicated their career to the clinical treatment and medical treatment of obesity. If there's a specialist, or many of us, the ones here who are watching this video right now, why don't more people seek medical help they need for their weight? It's because they think that they have normal fullness. It's all they've ever known. I do treat people who don't use medicines for their weight loss. I have patients who don't use diets for their weight loss. I have other people, patients, who use all 5 of the tools in my toolbox. For many of these patients, they're now at a weight that they never thought was possible again. Some say they're their best weight in the past 20 years. Some say that they're their best weight since they were in high school. One of my current patients just told me, "I cannot believe that I did not ask for help sooner." I'm going to get on my soapbox for a minute. Treating obesity is my job, but it's also a passion. Treating weight successfully is probably easier than you think it is, but it's not easy. It's definitely harder than doing nothing. It is harder to say no to foods. It's hard to say no to foods when those around us apparently can eat them. When we're using food when we're happy, when we're sad, when we're bored, lonely, or tired. I'm going to start to wrap up my talk by leaving you with a message. It's a message I've been preaching for several years now. It's a simple sentence. Here goes. Treat or refer. Most of you, at least statistically, see a medical provider at least once a year. Statistically, also 3 out of 4 of you are overweight or have obesity. When was the last time your medical provider brought up a weight loss strategy that was beyond eat less and move more? Or just watch what you eat, as if we weren't already doing that? If your provider has the tools, or you as a provider have the tools, or have some training in obesity medicine, please use it. But if you don't have the tools to help your patients with weight, or the person that your friend, family member, or other patients are seeing, you should refer them to someone who does. Someone who understands that your hunger is not normal and has the tools to help you treat it. The failure to treat or refer you to a comprehensive medical weight loss specialist is medical malpractice. Just like if your blood pressure was 200 over 100 and you weren't sent to the emergency room. Just like if you had cardiac chest pain and you immediately did not go to the emergency room or be referred to a cardiologist. Treat or refer. Treat or refer. I'm going to end my talk reminding you that I don't see the ball correctly when I play tennis. My depth perception is abnormal, and right now there is not treatment for that. People who are overweight don't feel hunger and fullness correctly either. There are tools, luckily, to help them when treated by trained professionals. All of us who are watching this video now. When the world adopts a treat or refer strategy, when we as a society begin to treat weight medically as a disease, when this happens, we will begin to ace obesity.